Although I would just say that we should remember the biology of kidney cancer. The biology of kidney cancer is it's a VHL-driven disease. We shouldn't be surprised that VEGF receptor inhibitors, which are upregulated as a result of mutations and hypermethylations, have benefit down the road of treatment. Dan, I want to ask you, and Nizar started to talk about that. Now we're talking about, well, we have agents in the front line that are approved, we have agents in the second line are approved, and more patients are getting to the third line. So is there anything that we would do different in thinking about third or fourth line therapy for a kidney cancer patient than what we've mentioned? Identify the patient that's progressing because of disease, not because of pseudo-progression. Identify the risk factors associated with that patient and comorbidities to make sure that they could tolerate treatment. But it seems like we're going to see more and more patients getting to further lines of therapy that, again, an editorial comment, it's going to make it much more difficult to start to ask and answer questions scientifically with new agents, which we'll come to in a moment, in these populations of patients because they will have been exposed to so many agents before getting to an experimental trial. Your thoughts?
Yeah, no, I think this is really important to take a step back here, and I want to go back to what we said at the beginning about goals of therapy. So one of the things I do with my patients every time we make another treatment selection is we revisit the goal of therapy, because in the frontline setting, there's a different set of goals of therapy than we're in the third line setting. In the third line setting, I'm rarely looking at a patient saying, I'd like to get you to a durable PR, CR situation where maybe we can even take a break from therapy or something. That conversation is gone. Those patients have had multiple progressions, and in all likelihood now we're talking about therapy for life. And the goals of therapy now get a little more balanced, because now we're not talking about cures or even these durable CRs. We're talking now about kind of, can we just get cancer control? Can we prevent the deterioration from the disease causing your quality of life to deteriorate, and balance that against your cumulative effect of toxicity? So the difference in third line or fourth line, and I don't know if you have a fourth line question lined up for us, Bob, but I'm going to take fourth line on as well. So third and fourth line, the difference there is now when you're dealing with not just the toxicities of that drug or combination, but all the inherited complications from both the disease and the cumulative toxicity that that patient has brought to bear to that situation. I mean, I'm not trying to sound negative, you know, but this is really hard on people. And a lot of our patients just tire out. It just gets to the point where it's just too much. I'm humbled by what these people can do sometimes in this third or fourth line setting of therapy, that they can keep fighting, knowing what they've had to put up with, and knowing how many patients, you know, succumbed or had difficulty before them. That said, there are some of these patients, and we've seen it with other classes of agents, that just tolerate this stuff pretty well, you know, and we got these patients that are going for a few years on these drugs, and they don't look that bad. So just like the disease has a spectrum, the tolerance has a spectrum. And what we find is that there's probably a selection of some better tolerant patients in that third or fourth line setting, and then others that are petering out. So that's what I'm dealing with in the mix there. And that's what I balance in terms of how hard to push, whether it's combinations, whether it's a dose reduction of the different therapies or what have you.
David?
So I would agree with everything that Dan said, except for one small caveat, which is in both the Nivo 025 pivotal trial and the cabozantinib METEOR trial, patients were allowed to have failed more than one treatment. So in the case of the Nivo trial, you could have failed 2 TKIs to be on that study. So we have, and there's a mix. There's a pretty good percentage of patients who had failed more than 2. So I think in there we have 2 trials with an OS improvement. In the case of the Nivo trial, we have quality of life improvement. In the case of the METEOR study, we have PFS. So I agree, patients drop off, patients get beat up, but we have drugs that work now both in the second and the third line, depending on how you approach things. So that's a good problem. And I think getting back to the Cabo story, it's not surprising to me that the drug beat everolimus. I mean, we've seen in a couple of trials, Tom did a trial earlier, you know, comparing VEGF and mTOR. I'm not surprised, as you said, that VEGF is the dominant pathway that a VEGF agent beat mTOR. But the amount that it beat it, 7+ months of median PFS, for example, in that study, OS, which we've never seen with a VEGF TKI. I mean, that's pretty impressive, and that suggests, as you were mentioning before, that these other pathways beyond VEGF have a role, like MET and AXL, these sort of potential escape pathways that tumors use. And I guess sort of to wrap all this up, I would hope that while we didn't come up with predictors of these drugs when we had IL-2 and when we had Sutent, maybe with drugs with different mechanisms, we could actually come up with predictors. They were already using prediction tools with PD-1 in lung cancer, so there's hope there, potentially in renal. And similarly, if we're working with an agent, that targets these other pathways, maybe we can figure out who benefits from that.